Hello and good evening. I'm Adrian James. I'm President of the Royal College of Psychiatrists, and a big welcome to this Royal College free webinar in collaboration with NHSX. And this is on the Mental Health Digital Playbook, how digital technology can help deliver service improvement and transformation. Now, I was at a meeting yesterday when a group of us were talking about what are those changes in mental health policy and practice that could really make a sort of paradigm shift to the care that we provide for patients. And this is one of those areas. So all 550 of you who have signed up to this webinar, and 550 and counting, you need to listen up, and I'll certainly be listening up and being very attentive to this. I'm delighted to be joined by my fellow chairs, Lisa Hollins, who's Director of Innovation at NHSX, and our very own Dr. Paul Bradley, Chief Clinical Information Officer at Hertfordshire Partnership Foundation Trust. Paul, of course, is our Specialist Advisor on Mental Health Informatics, appointed earlier on this year. Now, the power of digital to enhance and improve patient pathways is very well known. And this has, of course, been enhanced by the pandemic. Of course, the pandemic has also highlighted digital exclusion, and that's something I've raised with the CMO himself, and something we need to address. So there's a lot that we need to do in this space. And really, amazingly, NHSX have launched a library of digital playbooks in other branches of medicine as well, but we're one of the priority areas, so that's really fantastic. The playbooks are on the website, and the mental health playbook was launched on the 5th of July 2021. Now, the playbook showcases digital solutions that can help solve the challenges that we and our patients are all facing in relation to the delivery of services and access to services. The role of digital technology, the experiences of those who have led some of the changes, the challenges and the successes as well, the range of digital tools, but also what are the future opportunities. So this is a really exciting session. So there'll be time for questions after the speakers. Please use the chat box to post your questions. If you're tweeting, please use the hashtag RCPsychLive. And now I'm going to hand over to Lisa, who's going to chair the webinar, and then Paul is going to pick up the Q&A at the end. So over to you, a really exciting session.
Thank you very much, Adrian, and thank you for such a warm introduction. So it's a real privilege to be here, and my job is to shepherd us through the next session. So I'm going to be making sure we all keep to time, and you have the advantage of being able to speak to and hear from all of the speakers tonight. So I'm going to move you on to the first presentation really quickly, so we get to hear from Dr. Leah Ali. So Dr. Ali is an adult liaison psychiatrist and the CCO advisory panel of the Digital Health Network. But for me, I know Leah as my colleague at NHSX, who is leading a lot of the national advisory work for digital mental health. So I'm really pleased to work with her, and I'm even more pleased to hand over to Leah to go through the national overview now.
Thank you very much, Lisa. Thank you so much to everyone for joining us today for the launch of the Digital Playbook for Mental Health. Could I have the next slide, please, Kisha? The playbooks have been developed, as Adrian said, in a number of clinical areas to support teams to reimagine and redesign care pathways by showcasing tried and tested technologies to solve real-world problems. For the mental health playbook, what we did was we used the methodology that you can see pictured here to reflect the need for evidence-based clinical systems that are integrated, biopsychosocial, and patient and service user-centered. This could only be achieved by the incredible engagement that we had from patient and public voice partners, clinicians, commissioners, the charity sector, and our NHS England colleagues. So a huge thank you to the many people who contributed to this work in this way. Could I have the next slide, please? We used a design sprint process to structure this collaboration, which allowed us to identify certain important themes that you can see some of them listed here. These themes then guided selection of best practice case studies in everything from electronic prescribing to patient-held records. A number of the studies come from something called the Global Digital Exemplar Programme. So they have a really high level of evidence to support both their implementation and clinical use cases. And this is something that is really very important to us in thinking about what sustainable and successful digital transformation looks like. Next slide, please, Kesha. The playbook link, I think, is already available for you in the chat, and it would also be linked to on the slides, these slides that I have and the others from the other speakers, that you'll have available to you after the webinar. And we've also got some links to some other pieces of ongoing work, such as the usability survey for users of electronic patient records. We would strongly encourage you to look at that, because the outputs of that will really help determine and define what more work we need to do. What you'll find on the playbook page are a huge breadth and depth of case studies arranged by pathways or scenarios that frame real-world problems, such as, I want to be able to communicate easily with patients and help them to access support, or I want to use analytics and dashboards to provide the best care possible at the point of care. For me, one of the greatest joys of working in frontline health innovation is meeting people with incredible ideas who get things done and really improve healthcare systems. That's why today we've devoted most of the session to them. We'd love to have presented every single case study to you, but as time is limited, we've selected a few that we think will demonstrate the breadth and depth of digital transformation work going across the whole of mental health care. The playbooks include links to more resources and contact details for each case study. So even though the presentations here today are necessarily brief, you should be able to access much more information via the playbooks. Thank you very much, and I'm going to hand you back to Lisa.
Thank you, Leah. That's a really fantastic overview, and I hope people are accessing the digital playbook already. But I'm going to quickly move us on to Dr. Barbara Arroyo, consultant psychiatrist at the South London Maudsley, and Dr. Arroyo is going to present the work that she has done.
Thank you very much for the invitation and for the opportunity to be here today sharing what we're learning, because it's a live project with our personal health record. Can I check that you can see my slides?
We can, yes.
Brilliant, thank you. So as Leah said in her introduction, our project, this project, sits under the scenario, I want to be able to communicate easily with patients and help them to access support. And it features as an online platform for virtual working with patients and carers to support self-management and more personalized care. So this is a personal health record that we launched last year, so we're just over the year mark, and we call it Beth to help with our local implementation, but it belongs to that broad family and how it works in mental health services. And we use the term Beth, short for Bethlehem. Now, as a PHR, it speaks to 3 levels of care. So the first one is to connect with your care team. The second one is to promote mental health self-care. And the third one is to increase the choice of autonomy for the individual. I'm going to play a video with the features, because that's how best to show them, and then I'll tell you more about the story.
Beth is a free and secure way for our patients and carers to stay connected with their care team. What can Beth do for you? Set up and track personal goals on the Beth webpage on your phone or PC, and record and share what is important to you with your care team. Coping strategies. Create and track coping strategies on your mobile. Have a list of coping strategies that you know work for you. Please note that coping strategies and goals that you add to Beth will be visible to your care team online. Messaging. Communicate with your care team on the go. If you have any questions, write directly to someone on your care team. You can also view all of the members of your care team using the following tab. Appointments. View any appointments sent to you by your care team in the Beth calendar. Video links in your Beth calendar bring you straight to your online appointment. Assessments. Complete assessments that your care team send to you on the go. Care plans. You can also view agreed care plan summaries from your care plan team on the Beth web app. Physical health. View summaries and advice about your physical health on the Beth web app. Visit the Get Support section of the Beth web app for free online guidance and support. COVID-19 support and various crisis lines are available. Other features of Beth include the secure online diary and the mood tracker. Both of these features are completely private to you and cannot be viewed by your care team unless you choose to show them. The majority of features on Beth can be used by carers and anyone else that may want to use them. If the person you are caring for has signed up to Beth, when you link accounts, you will have the ability to contact that service user's care team. Please note that any information or messages belonging to the service user will not be visible to the carer. Beth version 1.2 has now been released and brings new features to the web app. See upcoming events that your care team has shared with you, and select tags to set your preferences so that you only see events that matter to you. To sign up now, visit beth.slam.nhs.uk. Input your first name, last name and email address. Set and confirm your password. If you're a patient, check the patient box. Otherwise, click the care, friend or family member box. As a patient, to get the most out of Beth, you will need to provide your NHS number. This will allow you to connect to your care team and take advantage of the features shown in this video. Finally, accept the terms of service and privacy statements, then click Create Account and you will be signed up to Beth.
Brilliant. I hope you enjoy that. So what Beth does, let me just move to the next one, is speak to digital transformation, the way we create systems that are more efficient, with better experience and improve patient safety by using digital technology of those problems that we identify on the ground. So our aims with these personal health records is to bring care closer to patients, to empower people, to improve safety and improve the efficiency in staff workloads, and to stay connected and to talk to all the digital systems and meet the NHS long-term plan goals. And it's been a significant journey. I can't name all the people that have been involved, from patients, carers and colleagues, some of them even here. So thank you very much to everybody. We started this as the Global Digital Exemplar, and we've had streams of funding along the way from research, from the charity, and from more recently Keen's Health Partners Mind and Body, who've not only brought their funding, but also brought their energy, their ideas and their enthusiasm to make it their most better product. And we have a very strong partnership with Islam Recovery College, because this product is, the main users are our service users and patients. So they're a very big ally for us, for people to know. And we recently conducted a feedback survey, and what service users told us is that what they like the most is the communication with the care team, the easy, finding the appointments, the sleep and mood trackers, to see who is in their team, and to share the crisis plan when convenient, when they need it. Some of the things they'd like to see in the future is this becoming more of a mobile app, physical health tracker and wearables, rather than having to input yourself, appointment reminders, information about medication, and possibly a chat room. And some of the main barriers identified were digital exclusion, training practice, also, I suppose, just time to get used to it and the flexibility that it brings, and yeah, more awareness across the board. But generally speaking, people felt that their care didn't change, or for a significant number of people, it was positive or strongly positive. And the feedback we had from staff was that they liked that they was fully aligned with the care process model, so it's all talking to the same evidence that we got to provide care that is integrated with all our other digital tools, such as the electronic patient record and communication, that it helps and enhances communication with clients, particularly with around appointments, and the easy way of sharing care plans that can be easily updated. And people would like to see more of the assessment feature, including prompts and prems, and to incorporate documents. And the main barriers are the lack of time when you're doing real-time job to get used to something and a different way of working, and wanting more training and practice. But the overall people that replied represented various professional backgrounds, and it looks like the most used, or at least the ones that replied to the survey, were care coordinators and psychologists. And for most of those, they will recommend it to service users and carers and to another colleague. And this is where we're now in terms of numbers. So we're almost 1,000 users, of which just over a fourth is patients. Now, in secondary mental health care, we have that ratio 1 to 2, 1 to 3. But yeah, we would like to see that number growing. But we've compared, we understand that this is, a completely new way of working with more flexibility, etc. We compare it with other QI projects in the trust just to see what our local adoption and we did have a high uptake after the release, and then we have a continuous sustained uptake, which is good, and we provide an environment to do so. Now, our strategy going forward is, if we look at the type of contacts that we have, we want to focus on those that are, or those people that are already using video and other online features. And we're also working with digital inclusion pathways. So when people sign up, that they use this as a stepping stone to use and try Beth and see what works for whom and where. So thank you very much for listening, and over to you, Lisa.
Thank you very much, Barbara. A wonderful example of a patient-held record. So we're going to keep the pace and momentum. I'm going to move us straight on to Dr. Adam Drage, who's a programme lead for the Merseycare Community Mental Health Transformation Programme, and Caroline Gadd, who's a director at Holmusk and a founder of MASK, which they're both going to tell you about, which is a predictive analytics tool and a supervision tool for community mental health services. So over to Caroline and Adam.
Thank you very much, and thank you for the promotion to doctor as well. That was that's a nice surprise. No, sorry, I'm Adam Drage, and I'm just going to share my screen now. Okay, so I'm Adam Drage, and I'm a clinical service lead in Merseycare NHS Foundation Trust. And I'm also leading our community mental health transformation programme with a couple of colleagues. And I've been working alongside Caroline Gadd, who will introduce herself in a second as well, for the last few years, as Merseycare and Holmusk have been working in a really strong collaboration with the management and supervision tool, really making the most of frontline engagement in adapting a tool to make it as useful as possible for frontline practitioners. And Caroline, I'll let you introduce yourself.
Thank you for the opportunity to speak to you, everyone. So I'm Caroline Gadd. I'm the Managing Director of Holmusk here in the UK.
And so I'll start by setting the scene, really. In Merseycare, in our community mental health services, probably like many other NHS organisations and teams, we suffer from the challenge of having large and complex caseloads, which really has an impact on the flow through of our services. And these large and complex caseloads with challenges around flow and moving people and meeting presenting need is a national challenge that everyone in mental health is experiencing. And that led to the community mental health framework stating the need for radical change of the community mental health model. So in Merseycare, we've been early implementers in the community mental health transformation programme. And last year, we were just about ready to go with our transformation programme, and then COVID happened and made all of our existing challenges even harder. So some of the challenges that were already there and were made worse by COVID were that staff were feeling overwhelmed with really high complex caseloads. Because of those high complex caseloads, it was really challenging to identify the right people to move back to primary care so that we can continue to offer structured care to those who need it most. And because people are so busy, they can't always be present in meetings to discuss those complex patients. So if the person isn't present in a meeting, the right patients might not be discussed with the wider MDT. And there are real challenges just because of the complexity and size and vast amount of work in making sure that we can identify who are the people right now who need our care and intervention, who are the most vulnerable people who we need to be focusing our attention on now. Throw into that the challenge of mental health workforce shortages, so vacancies, sickness, throw COVID in there and think about the impact of staff who are shielding, people who are being redeployed, COVID sickness. And you can see the challenges of trying to transform the community mental health system. Despite that, in Merseycare, we've been continuing to transform our community mental health services. And one of the key reasons we've been able to do that is because we've got the management and supervision tool already embedded within our teams.
So MAST is a decision support system, and it uses data that you're already collecting in the clinical records. And MAST provides a visualization tool using that data, which can evolve as you move through your transformation programme. One of the most important things that we learned as we rolled MAST out in Merseycare was that early engagement with frontline staff was absolutely imperative, because then we got really strong buy-in to using the system as part of the MDT and as part of day-to-day work. So we found that early engagement really kind of facilitated the behaviour change, which then facilitated a strategic change at more of a system level. So it's really in place to provide consistent insight wherever you are. So that really reduces the reliance on the presence of individual staff and provides a much more joined up approach to care. If we go to the next slide. So underpinning MAST is some predictive analytics, so a risk and complexity algorithms. The risk of crisis algorithm has been fully validated now in 6 different sites using different electronic health records, and it estimates the likelihood that somebody will need to use crisis services in the next 28 days. And then complexity adds another dimension to this risk stratification, enabling clinicians to very quickly see cohorts of people who are going to consume more resources than others. So people who are high risk of crisis and have a lot of complexity in their life, compared with those who might be further along on their recovery journey, lower risk of crisis, and perhaps even ready to move on from community mental health services. So this approach informs decision-making on a day-to-day basis. And this screen shows some of the decision-making solutions that are provided by MAST. So MAST provides decision support around identifying the most vulnerable people within vulnerable communities. It can also rapidly identify people who are transitioning from hospital to community or from one community service to another, to make sure that those individuals are rapidly followed up and supported. We can see that it supports the individual person's risk of crisis over time. So it's easy to spot patterns of risk of crisis over the course of a year and anticipate those further. But also MAST provides a tool to consider staff workloads as well, based on this consistent risk and complexity approach, which is a really helpful way, I think, of monitoring staff well-being because of their caseload sizes.
So it can be really hard to quantify the impact that a tool like MAST has had on services, because actually you're giving practitioners a tool that can help them to do what they're already doing far better. But there are some strong indicators around how MAST has enabled us to better achieve some of the things that we were struggling to achieve without MAST. One of the things is our community mental health caseloads. We've always tried to make sure we can identify the right people who are ready to transition back to primary care, so that we got the capacity to meet presenting need within our services. And what you can see is, since MAST was introduced, the CMHT caseload sizes have been gradually reducing over time in a safe and steady way, because we've been identifying the right people to move on. But then around September, when we launched our transformation program, we had a significant significant increase of, well, a significant reduction and sustained reduction of our caseload size, because we were able to match up the MAST tool alongside our community transformation program and really start seeing the success of the tool and of our program. What you can also see is that MAST has helped us to meet some of our really important KPIs, such as providing care plans in a 12-month period. And care plans are so important because they enable us to provide personalised care. And what you can see is the longer that MAST has been involved, the better our care plan completion has been amongst those who are using MAST. And it's the same for physical health assessments. Again, people with severe injury and mental illness, it's so important to consider their physical health. MAST has helped us to identify where we need to be, who are the people that haven't had an assessment, and making sure it gets done. And again, as MAST has gone on, we've seen a nice steady improvement in performance there. And likewise with people that are being followed up after discharge from hospital, a significant improvement in people that are getting that follow-up within a 72-hour period since we've deployed MAST across our services.
And we've also been looking at the use of crisis services overall in Merseycare as part of this wider transformation programme. And actually what you can see here is that there, towards the end of 2019, there was a kind of switch over really in the use of hospital versus community crisis services. And that happened purely because Merseycare introduced their new crisis pathway, their new acute care pathway, which really helped to reduce acute admissions. But you can see that as MAST was introduced, actually, we've seen now, since then, an overall reduction in crises seen both in terms of hospital admissions and in terms of community admissions. So community mental health services, because of this transformation and because of using MAST together, are working out how to keep people safe in the community and maintain them there.
Another measure that I really like, and I think this is really key of our community transformation program, is addressing the issue of people that are inactive on caseloads. We know that teams that have high complex caseloads are quite likely to struggle to see people as quickly as they want to see them. And what you can see here is people in the green line who have had no contact in the last 4 weeks. Since November last year, where we put a real deliberate attempt in to try and use MAST to identify people who haven't been seen and who hit a certain sort of number of boxes that means that they should probably be prioritized for contact. We've used MAST, we've deployed staff to use MAST to contact these people, and we've seen a reduction in inactive people. So people who haven't been seen in over 4 weeks started reducing from about 55% of the caseload down to closer towards 40%. But the real dramatic improvement here is we did a parallel project, which was looking at people that have had no contact in 20 weeks, getting MAST to identify those people and giving access of MAST to people to start contacting those people. And we can see a drop in the number of people who are inactive on our caseloads over a 20-week period from 25% of the caseload down to almost 10%. So that's a massive improvement in quality, because only 10% of people haven't had a contact within the last 20 weeks compared to sort of 25% before we started the project. And that's been sustained and has continued to actually drop, and we wouldn't have been able to do that without having MAST giving us those data insights on who the right people are to contact and when. So very quickly, MAST has really helped us to transform and continues to be a key enabler of our community transformation program. It's all well and good having a transformation program, and it's all well and good having a good tool like MAST. But if you have both of them, you can really start to get the data that helps you to understand what you need to do differently and to stratify how you're going to do that. And a really good example of how MAST has really been ingrained in our staff is I recently did an interview with about sort of 12 people, and one of the questions was, tell us about digital transformation and how it's improved patient care. And every single person in that interview who was internal to Merseycare talked about MAST and the impact that MAST has had in improving patient care. So it's really throughout our workforce. And that's because of the improved flow of patients, because of the ability to prioritise our most vulnerable patient, identifying unmet needs, reducing inactivity, et cetera, et cetera. So final slide for Caroline.
And so what's the future for MAST? So we're already rolling MAST out in a number of other trusts across the country, but we have a vision that there would be consistency of insight across all community mental health services, whether that's early intervention services, addiction services, older adults, or community mental health teams. And so we're working towards delivering those system level insights so that there's consistency across pathways, so that clinicians can deliver more effective care. Thank you very much for your time.
Thank you very much.
Wonderful, thank you, Adam and Caroline. It's really good to start seeing how predictive tools can help clinical teams, and some very good data there that we can have a look at. So I'm going to move us swiftly on to Mike Jones, who's the Associate CCIO at Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust. And Mike is going to introduce the system-wide transformation that they're doing in his patch. So over to you, Mike.
Welcome, everyone. Thank you for letting CNTW have the opportunity to come along today. I'll just give you a very brief overview of the trust. As has been mentioned earlier, we're a global digital exemplar, and three of the things you're going to see today are part of the portfolio of the work we've been doing over the last few years. We serve a population of 1.7 million. We have over 7,000 staff. We sit across 7 local authorities, 6 ECGs, and have a turnover of just short of £400 million a year. In terms of physical size, for those of you who are good at geography, we go from Whitehaven to Berwick-upon-Tweed down to Middlesbrough, so we have a very, very large patch. In our last 2 CQC visits, we've been rated outstanding on both of those last 2, which we're very pleased about. But I'll get straight on to the first of the playbooks, and the first person on is Laura Gordon, who's an informatics project manager.
Hi there. One of the first projects to kind of talk you through is mobile working. Next slide, please. The requirement, as Mike pointed out earlier, the trust covers geographical area of 4,800 square miles. We have staff working across 70 trust sites, as well as within patient homes, GP practices and community-based sites. As we're a mental health and LD trust, we've obviously got patients that are highly vulnerable and can often be high risk. Staff frequently travel between multiple appointments each day, with limited or no availability to return back to a trust base. Therefore, they are required to access data and information when attending assessments and appointments, and also make sure that information is up to date for other members of staff throughout the day. Next slide, please. As a solution for mobile working, we implemented mobile connected laptops to all staff with an always-on connection. There's no requirement for additional passwords. It's a one-password system, so no additional authentication or tokens. We also implemented direct access, which is a reliable, authenticated, secure, bi-directional connection to all trust systems, allows staff access to the EPR system, MS Teams, GP data, and other documentation regardless of the location. We also updated processes and tools to ensure ongoing management of and security of the solution. Next slide, please. And briefly, some of the benefits that we've seen from implementing mobile working has been improved ability to access and update service user information rather at point of care. So the information is available immediately. Improved ability to personalise treatment for patients due to the immediate access to both trust, GP and regional information. An example of that is our street triage teams have been able to use mobile kit and reduce the number of section 136s by 80% across the North East. We've seen improved compliance with staff essential training, and also it's provided a supporting tool in trust business continuity and disaster recovery, because we've got less reliance on trust direct network lines, because staff can access Wi-Fi and 4G. So that is a very quick overview of the mobile working, and I'll hand over to my colleague Lindsay Jones.
As Laura says, next person you'll hear from is Lindsay Jones, who's one of our informatics project leads. Hopefully.
Oh, sorry. Yes, sorry. Can you move on to the next slide, please? Yeah, as Mike says, I'm Lindsay Jones. I'm a clinical project lead, and I've been rolling out at-a-glance boards throughout CNTW for the last few years. Next slide, please. So our requirement was we were asked to find a solution to remove handwritten whiteboards or similar that were being used within inpatient wards. The solution needed to be able to provide all healthcare professionals on wards with an easy to view summary of the key information relating to the inpatient. And in addition to that, also support patient and carer communication and support multidisciplinary teams to flag up and pick up tasks that they may need to be completed or actioned. Next slide, please. So as a solution, we developed an electronic record or an electronic report in-house, and we provided wards with two 55-inch monitors, one being held in the nursing office and the additional in a meeting room where they hold the MDTs. At-a-glance reports were designed specifically around each service or each pathway, with slight amendments on detail depending on whether it was children's or adults or older persons. The report provided different colours for showing missing information or information that was out of date or due for review or update. The at-a-glance boards are frequently used by our discharge facilitators and enhanced bed management team to support the flow of patients through the inpatient wards. Next slide, please. Apologies for the size of this slide. This kind of just shows you some of the headers of the information that kind of displays within our at-a-glance boards. These will be kind of circulated, so you've got them to review at your own time. So we've got obviously client details, that length of stay, intended discharge dates, down to mental health status, when clozapine bloods might be due, etc. But you can have a look at those at your own time. Next slide, please. So benefits, we've seen many benefits since installing the at-a-glance boards within CNTW. We've reduced clinical duplication of information, as all information is held within the electronic patient record, and it's displayed on the board when the information is refreshed within the system. This reducing the use of manual handovers and ward diaries. We've seen a 59% increase of improved data quality in key data fields throughout RIO or through our electronic patient record, and this is due to the colour coding and visibility of the information within the at-a-glance boards. We've also had financial savings from staff using the task list, which supports ease of access to information in finding tasks allocated to them from the MDT. And in total, we've saved approximately 32,700 per quarter over the 60 inpatient wards that are using the at-a-glance boards. Next, and I'll hand back to Mike.
Right, and I'll now hand on to the last of our three lovely presenters, and this is Stuart Little. He's also informatics project lead.
Thank you, Mike. Hello, everyone. Thank you so much for having me here today. I'm just going to give everyone a brief update on our online consultation solution. So next slide, please. So back in January 2017, the Trust carried out a proof of concept with our deafness service using Skype for Business, following which an evaluation was undertaken, and there was several trends and positive experiences that were identified as a result, which indicated that a solution designed to offer online consultation with appointment management functionality and easy to access for both our service users and staff would be very beneficial to our Trust and service users. So Skype for Business was a business-to-business solution, and therefore it was not suitable to be used for wider implementation as a solution for online consultations. So as a result, a number of requirements were developed and brought up. And as you can see on the screen, our key requirements for the online consultation solution was to provide an online consultation solution to contribute to improving access to services for service users, but also improve service users' choice for treatments by offering online consultations. And lastly, to provide an online consultation solution that enables our service users to access care via their domestic or care setting. Next slide, please. So to identify a suitable online consultation solution, an analysis went into different systems that we carried out using a framework process instigated by G-Cloud to establish a solution that would be most compatible to our Trust requirements. Through using the G-Cloud marketplace, we identified one modality, one consultation, as a preferred one consultation solution. The one consultation solution allows our clinicians to link up with our service users using a video call via the internet. As part of this, we had a free pilot of online consultation that took place over 3 months with 5 identified pilot teams. With the chosen solution, obviously COVID took place and that significantly increased our use. And as a result, we implemented online consultation across 141 teams within the Trust, with over 3,000 staff having access to the solution. With the solution, it provides one-to-one consultations or groups via a unique link. And at the end of our online consultation, we give service users an opportunity to answer a survey for them to complete. As part of the project, we also commissioned an academic evaluation via Sheffield Hallam University in relation to the project. And as a result, a paper has been published on perceived mental health service user suitability for video consultations and has been accepted for publication. And also a second paper has also been accepted for publication in America Journal. So a great thing about the project, because we have focused very much around patient safety, we've actually been nominated for the HSJ Award, which is a fantastic achievement. Next slide, please. So just to kind of highlight some of the benefits, since having the online consultation solution, we've had over 56,000 online consultations, and the Trust is currently averaging at 3,500 per month. From the staff survey, 96% of our service users would like to continue to have future online consultations as part of their care, which is fantastic. And also, some of the benefits really that we've picked out just to show you today is that with our Trust-wide online consultation, we'll reduce the need for patients to travel to a hospital site. So 3,834 service users out of the 4,700 have responded to the survey have saved up to more than 30 minutes or more of travel time. And as Mike said, we are a large geographical patch across the Trust, so it's a significant amount of time saved for our service users. Also, another benefit that we've highlighted here is the reduction in CO2 emissions for our service users. So service users will have the ability to meet digitally and therefore not have the need to travel to clinics. And from a sample of our service users, it's found that they've saved over 24,935 miles. And this equates to 30p CO2 emissions saved per consultation. So it's had a significant impact on the Trust, which is very positive. And just to end, I just wanted to bring up one of the service users' quotes that we retrieved, and it was just, I can't believe what I've gone through with me and how this has given me my life back. It has been an effective as face-to-face appointments, and it's much better having online consultation solutions. So thank you very much. I'll hand back to Mike.
And thank you so much, Stuart. I think we're going to go straight to questions. And a huge thank you to Mike and his colleagues, who's given us a fantastic overview into the wide range of work that they're doing. And I'm joined by Dr. Paul Bradley in the questions, who is going to switch the camera on, and we will see Dr. Bradley in a second. Great. Okay, so there's just a couple of questions that I had from the many questions that people have asked that I wanted to put to the panel, and then I'm going to hand over to Paul, who will pick out some questions and also ask people if they have any further questions. And the reason I'm picking these two questions out is that they're very fundamental questions that people ask a lot about digital products. So the first question is for Barbara, and it relates to Beth. And there's a number of questions around: are patients happy to share their data? How did you onboard patients? And what's the rules really in terms of consent and sharing data? Would you mind saying a little bit more about that?
Yes, so I mean, it was a brief presentation, and there's a lot more information. So we take security and confidentiality very, very seriously. Otherwise, it would be a non-starter in our place of work. So everything is held in the electronic health record, and the way I explain or I see it is that Beth is a window to parts of those records. So the information is actually not being moved anywhere. And in the process of signing up, there are quite a few security features, including a human verification one. So when the patient wants to sign up, the care coordinator or somebody that actually knows the person will need to verify that that is the person that wants to sign up. And then this login process, and there's ways that we can stop the sharing, and it's always the latest information. So there's quite a number of features that means that everything is as secure as and tight, and yet user-friendly as possible.
Wonderful, thank you. That's really great. And then the final question from me before I hand over to Paul was for Adam and Caroline, who talked about the MAST program, and there were a couple of questions around costs, and that mainly related to does it require more staff? What impact does it have on staff, and are there any additional staffing, and do staff change their way of working? So I'm just going to hand over to Adam to see if you would mind just saying a few comments about working patterns with his program.
Sure. Yeah, I'll start it, and then Caroline, you might want to add. I'll answer it from a Merseycare perspective. I think one of the key things is there's absolutely investment in terms of making sure you've got dedicated resource from within your team to make it work. I think one of the things that you can do wrong with digital transformation is just try and buy a solution and expect it to do the magic. And I think one of the key things that we did within Merseycare was we made sure, whether it was launching MAST the first time round within our community mental health teams, or whether it was doing it as part of our transformation program, we had dedicated resource inside that saw our role as supporting the launch and deployment and business change and clinical business change alongside MAST. So there's investment that you need to put in terms of freeing up some capacity within your team to get leaders to really help to roll this out. You get that investment back, because absolutely, if you do that clinical business change bit right, you will change practice, because ultimately you're giving a gift to your staff. Our practitioners didn't see this as oh my God, here's another tool we've got to use, which is how a lot of people couldn't see these things. They saw it as, thank God, this is making my life easier. So a lot of practitioners see this as a gift, as an investment, and therefore practice just naturally changes because they've got the right information to help them to do their jobs easier.
Fantastic. And Adam, it sounded like the dedicated resource was almost like a change management resource, which would help you with the system rather than additional clinical staff. Is that right?
Yeah. So we didn't employ any additional clinical staff to do this. This was an add-on. This not an add-on. This was, like I say, an enabler to the workforce to do things differently. The additional investment was freeing up somebody who can really support the team to understand the benefits of the tool and what they might want to do differently. From a practice perspective or from a team system and process perspective to make best use of it.
Wonderful. That's really good to hear. So I'm going to hand you over to Paul Bradley now. He's going to take you through some of the questions in the chat.
I'm going to come on to the team from CNTW. I mean, thank you all for great presentations. Hot topics in the chat around video consultation, the last thing to be talked about, which I think has played a big part in everyone's lives for the last 18 months or so. I'll put a couple of questions and maybe you can pick them both up. So one was about DNA rates. What online consultations did to them and maybe what's happened over time. And the other one I think related is with the recent negative reaction there's been to remote care in general practice. How are you tolerating that or working through that in mental health care in CNTW?
If you can do the first one, Stuart, that would be good.
Yeah, of course, thank you. So in regards to DNA rates, there's a couple of our services have reported that they have seen a decrease in DNAs. We did have DNAs as one of our benefits, but we have put that on hold because it was unfair to do a comparison due to COVID, and we wanted to wait until business as normal was there so that we could do a real life comparison, because I feel like with COVID it didn't give a true reflection.
And I think that the second part of the question, Paul, is that our experience appears to be a very positive one in terms of how we've been managing online consultation, and it appears at this point that they don't mirror what primary care have been saying, not in exactly the same way, but we'll be doing fairly constant surveys, with our population anyway, to see if that changes over time. But at this point in time, it doesn't seem to be as negatively impacted as primary care does.
Great, thanks. I think I'll come back round to Barbara and to Beth, because I think there's something about you also showed briefly in the video there, the link to video consultation. I know that's one of the features of Beth. I wondered if you want to say a little bit about that and the links to your EPR, which a few people have asked about in the chat there.
Yeah, so my understanding, so the supplier that we work with works with all the trusts. So my understanding is that our digital services have helped with that integration locally, but that there are other features as well that can be used elsewhere. Now, in terms of the video consultation, so we use this dashboard that tells us the type of contact that people have. And what I'm interested in is in the people that have in video, whether that moves on to Beth, which is more secure and sustainable all the time, because also it helps the sort of the care team work together. So it's very efficient and hopefully it's a win-win scenario for both. So what we're doing is we're following that through as we change our behaviors and we work more hybridly or more on site. But I don't think it's replacing anything. I think it's enhancing what we've already got. It's giving more flexibility, another channel of communication and so on. And it just needs a bit of time for people to get used to it.
I think I understood the answer to the question, can Beth work with other trusts, other EPRs, is yes, the supplier can, and maybe that's a one to follow up outside. Shall I come back round to Mast? There was a question I've just seen. Were service users involved in design? And have frontline staff have there been any frontline staff who haven't embraced the digital aspects of it so much?
Okay, so I'll kick off with this one. So during the design and development phase, we had a service user and carer panel who were deeply involved actually in the co-production of Mast, both in terms of the data that was used in the development of the algorithm, but particularly in the visualization of that and what they wanted to be presented back to the health professionals. Now, I know that trusts we work with continue to work very closely with their service user and carer networks around the implementation of MAST and its ongoing development. In terms of frontline staff, of course, there are staff that don't fully embrace it. There's a normal distribution curve, of course, but we have seen some quite dramatic turnarounds of staff who, when they started their training of MAST and being exposed to it, were really kind of anti-use, who then really transformed their view and started to embrace it. But Adam, you could probably add to that one, that question as well.
Yeah, I would have said, of course, and you said it, so I'm glad you said that, because yeah, of course, absolutely. I think one of the key indicators is when you look at the usage stats, once it became business as usual, MAST, essentially it's optional because people can opt to use it. You're not entering information into it, you're using it because you choose to use it because it makes your life easier. And there was always going to be a risk. And my fear, I'll be honest, was as we stepped away from the project and let services just use it, that usage would drop and it would kind of become, filter out. And actually usage sustained really, really high, and probably I would say it grew. It certainly sustained at high levels, and that was across all teams with multiple staffing groups. So usage sustained itself because people opted to use it because it made their life easier. And the question actually, you had that positive snowball impact, which was it's amazing, but it causes challenges because everyone heard about MAST, everyone heard about the impact that MAST was having. So all of the other services in Merseycare were saying, we want MAST, can we have MAST? And actually the demand was far greater than our ability to kind of make it available for every single type of service. So the majority of people, and even those that don't use it, love it or want it.
Thanks. I think I saw a question from someone in CAMS in Merseycare who's interested. So let's follow up with that after the webinar.
Great. And I think we're coming back to me for the final question, which I think is for Barbara and the Beth programme, which is around can this type of tool reduce the repeated assessments that can sometimes happen within the care pathway? And over to Barbara and Beth for that question.
So by sharing information with the service user, with the patient, what we hope is that it will share that decision making and empower people to ask for the help when they need it and what they need. So yes, for somebody who's known and we've understood what their needs are and they have expressed what their goals are and we have a clear care plan, that would be in their power to then share at different stages of their life for people who may not know them, but that's already there. So the idea is that by people having more information at the tip of their hands, they can use it more efficiently and get better support when they need it. And that promotes engagement and a sense of autonomy. And we hope that will promote stability, because then you feel more resourceful. So yes.
Thank you very much, Barbara. So it's thank you from Paul and I. We're going to hand back to Adrian for the close.
Well, thanks, Lisa. Wow, that's just amazing, isn't it? The difference that these tools can make, and actually there they are. They're all out there transforming patient care. So a big thank you to Lisa and Paul and the teams both at the college and at NHSX, and a big thank you to Leah. You've done some incredible work on all of this, on coordinating it and bringing it together. So thank you. I was asked to mention the electronic patient records usability survey. We can put the link in the chat or send it out. Please give us feedback on that. That's really important. So we need to get out there and spread the news, spread the links. There's lots of links in the chat to all the things that you've heard about, to the playbook itself, but also to feedback on this webinar. So we'd really appreciate that. I mean, I just thought the personal health record at SLAM was absolutely fantastic. The decision support tool, MAST, lots of new acronyms, Beth, MAST, I'm sure there'll be more to come. The mobile working playbook and the impact this could have on the environment. I mean, looking at the sustainability element to this, that's absolutely incredible. I always like to look down to see who's actually here on the, well, still 254 people who are still attending. And I noticed that Hashim Reza is one of the people actually on the call. Now, Hashim was the chair of our informatics committee before Paul, and I think we're in a very strong position at the college. We've had people working on this for a long time. So a big thank you to Hashim for all the work you've done. We also rely upon our senior medical managers to really embed this in services. I noticed Ellen Wilkinson, who was medical director down in Cornwall, now chief clinical information officer there, also on the call. Two of my former trainees, Jeremy Sandbrook and Ernest Gralton, obviously hard at all of this. So welcome to you. Thank you, Jeremy and Ernest, and my predecessor, Wendy Byrne. So this shows really how important this issue is, that Wendy's on the call. So finally, a big thank you to say all of you for attending, for the amazing questions, all that you'll do for our patients in actually putting this forward, and also to the team at the college who actually coordinate these, so particularly Leah and Isabel. So thank you so much. That's really exciting stuff, and it's filled me full of optimism. So have a good evening. Enjoy your weekend when you get there.